Hi, my name is Miguel Mendoza. I'm studying medicine. I'm a semester, and in this video I talk about acute hydrophilic-polymer nephropathy and acute renal failure. Definition: hydrophilic cuttings are used on intravascular device to facilitate manipulation to minimize complications such as vasospasms during a procedure, tap thrombosis after a procedure.
This will be the second video in two-part video series on acute renal failure. In this video, we will discuss the clinical features, diagnosis, and treatment of ARF. In part 1 of this video, we defined acute renal failure, studied the etiology and types, and also the Rifle criteria of acute renal failure. Click here to watch the first part of this video. Discussing the clinical features of acute renal failure, and first we will talk about the pre-renal ARF. Most of the patients of pre-renal ARF have a history of poor fluid intake or a history of fluid loss in the form of diarrhea, vomiting, or blood loss. And most of the signs that are associated with pre-renal ARF are consistent with the findings of a dehydrated patient, like low blood pressure, tachycardia, feeble pulse, reduced jugular venous pressure, a decreased skin pinch, sunken eyes, dry mucous membranes. These patients may also have orthostatic hypotension. Low urine output is almost a consistent feature with pre-renal ARF. Renal ARF has different types of histories depending upon the etiology which causes ARF. A history of previous sore throat, which may indicate nephritic syndrome due to post-streptococcal glomerulonephritis, may present with a triad of hematuria, hypertension, and edema due to volume retention. Rhabdomyolysis is also an important cause of renal type of ARF. And patients with rhabdomyolysis have features like tea-colored urine and muscular pain due to breakdown of muscle fibers. These patients can also have a history of coma or recent seizures which may have initiated rhabdomyolysis. Allergic interstitial nephritis is also an important cause of renal type of ARF, and the patients present with fevers, rash, and arthralgias. These patients can also have exposure to medicine like NSAIDs. Post-renal ARF is mainly caused by obstruction to the urine flow, which can be due to urethral obstruction due to enlarged prostate in a case of benign prostatic hyperplasia, and these patients have features like urgency, frequency, and hesitancy, which are features of benign prostatic hyperplasia. Renal calculi can also obstruct the urethra or bladder and cause post-renal ARF. These patients present with flank pain and hematuria. Some words on how we diagnose the type of ARF. Blood electrolyte profile is very important, which shows a raised serum urea and creatinine concentration. Various type of electrolyte abnormalities are present, like raised serum potassium, a raised serum phosphate, and decreased serum calcium concentration. Urine analysis is also important, which shows a low urine volume. In pre-renal type of ARF, urea concentration of urine is greater as compared to creatinine, and osmolarity of urine is raised. In renal ARF, we can have red cell casts which are usually immune mediated. Renal imaging is also an important modality of investigation, which involves X-ray abdomen and ultrasonography, which are usually helpful in cases of post-renal ARF to detect stones or enlarged prostate. Renal biopsy helps in pathological diagnosis of conditions like immune-mediated renal damage. The treatment of acute renal failure is mainly associated with correction of the fluid and electrolyte imbalance, and also the treatment of underlying cause. Please note that we will not be able to discuss the treatment of individual topics in detail due to limitation of time. Fluid imbalance is mainly associated with management of hypervolemia through salt and water restriction, diuretics like furosemide, Different type of electrolyte imbalances can occur. Most prominent of them are the hyperkalemia, which is managed by a dietary restriction of potassium, loop diuretics and potassium binding resins. Hyperphosphatemia is important complication of ARF, which is managed by using phosphate binders like aluminum hydroxide, which decrease the absorption of phosphate through the gut. Acidosis, if severe, can be managed by oral or IV sodium bicarbonate. And also a frequent monitoring of fluid and electrolyte levels of the body is required. Treatment of the underlying cause. Since the main problem in pre-renal ARF is less blood going to the kidneys, the most obvious step will be to improve the blood supply of the kidneys. And fluid replacement is done depending on the type of fluid lost. Blood can be replaced in case of blood loss. Crystalloids like sodium saline and colloids like albumin can be used in burns and pancreatitis. Inotropic drugs like dopamine are also used in case of heart failure to improve the contractility of the heart. Renal ARF. Glomerulonephritis is mainly managed by immunosuppressive drugs and corticosteroids. Rhabdomyolysis is managed by IV fluids in a magnitude of 10 liters per day. The treatment of post-renal acute renal failure is simple, as it involves the removal of obstruction in the form of surgical removal of prostate known as prostatectomy or stone removal. Thank you so much for watching this video. This was all about acute renal failure. Like our channel on YouTube for all the upcoming videos, and make sure to like our channel on Facebook for flashcards and upcoming notifications.
Application in medicine. The patients underwent renal transplantation in which the renal artery was implanted into right external iliac artery. Between January and June 2013, her serum creatinine level increased progressively over a 5-month period.
Welcome to part 2 of acute renal failure. Let's review a little bit here about what we were talking about. We were talking about Chem 7. We have the BUN, and we've got the creatinine. The BUN stands for the blood urea nitrogen. Remember, it's made in the liver. It is both filtered and reabsorbed, whereas the creatinine is the end product of muscle metabolism, and it is filtered and secreted. So let's look at our nephron once again. That's the loop of Henle, that's distal convoluted tubule, collecting duct, and you've got the toilet down here. Okay, and you've got the afferent and the efferent arterial. And remember what we said about the BUN. BUN is the blood urea nitrogen. It goes through and also gets reabsorbed. Okay, so that's BUN. And you've got the creatinine. Creatinine does not get reabsorbed, but instead goes out. Actually, a little bit gets secreted here. Okay, so if you've got acute renal failure, remember that the GFR, the glomerular filtration rate, is going to go down. So if that's the case, then your BUN is going to go up, just because of the fact that the glomerular filtration rate is lower, therefore not as much is being filtered, the BUN is going to go up. But because it's going by slower because the GFR is down, then more of it is going to be reabsorbed, and so it's going to go up by even more. That's opposed to the creatinine. Creatinine is going to go up. Why? Because the GFR is low. and the GFR is low because there's acute renal failure going on, and that means that creatinine is going to go up. But it's not going to go up any more than that because it's not being reabsorbed. And so what you see here is that the BUN goes up more than the creatinine does when you have a decrease in your GFR just based on the fact that there's lower flow. So lower flow means higher BUN to creatinine ratio. Okay, so what would be a number here that we could associate with it? So normal would be, for instance, 15/1. So if the BUN over creatinine, if the BUN went up by more than that of the creatinine, we could say, for instance, that this would go to a 2 and a 30. Okay? So the BUN would go up to 30 and the creatinine would go up to 2. So you go up by, instead of having a 15/1 ratio, you would have more like, instead of even 30, it would even go up higher, it would go to 40. So a 40/2 ratio, which is the same as a 20/1 ratio. So here we would see the normal ratio is 15/1, and it would go up to 20/1, or in this case, 40/2. And that would be from a low flow state. Now, what would happen here if for some reason there was a shutdown? A different type of acute renal failure. Acute renal failure not because there's less flow coming to the glomerulus, but instead because the actual tubules which line the nephron, something we call renal failure, if they weren't working. Well, what would happen is that you would still get a slowdown here because these cells are not working, and the BUN would go up. But it would only go up for one reason, and that's because the GFR is low. You would not get reabsorption of this BUN. And so what you would have is, this would be more of a pre-renal. What I mean by that is that there is a reduction in the flow coming here, and because of that you're getting the BUN increasing because of the low flow, and also the BUN is being reabsorbed because these cells are working. So that would be a pre-renal situation. Or in a renal situation, these cells are not working, and so if these cells are not working, the flow is going to be low as a result of that, but you're not going to get BUN reabsorption, and so it's going to go up. Instead of being 15/1, okay, it's going to go to 30/2, which is still the same 15/1 ratio, but they're both going up, but this is not going up more than that is, so it still holds the same ratio. So in a renal situation where there's a problem with the kidney itself, you hold and maintain that 15/1 ratio, but when there is a pre-renal state, in other words, there's not enough flow coming to the glomerulus, you're going to get a reabsorption of the BUN preferentially, and that's going to increase your BUN ratio to 20/1. Okay, so the bottom line here is that the BUN to creatinine ratio can kind of tell you what kind of renal failure you have. Is it pre-renal azotemia or is it renal azotemia? Pre-renal azotemia is where there's not enough blood coming to the kidney. Renal azotemia is where there's something wrong with the kidney itself. If it's 20/1 ratio, like this, you're thinking of pre-renal azotemia. If it's still 15/1 ratio, it's renal azotemia. Okay, another way of looking at that is just looking at sodium and water concentration. So let's go ahead and draw our glomerulus again, a little bigger this time. There's the glomerulus, the proximal convoluted tubule, loop of Henle, and then out. Okay, so pretend you're a nephron, and you've got two different situations. You've got a situation where you have a pre-renal situation where there is not enough blood coming in to the kidney, and you've got a renal situation where there's a problem with the actual tubules that are supposed to be transporting fluids and reabsorbing. In a pre-renal situation, there's not enough blood coming in, and you have a reduction in your GFR. Well, the kidney thinks that there's not enough volume, And the way the kidney regulates volume is by reabsorbing sodium. So if there's not enough volume, all the kidney's going to do is just try to reabsorb more sodium. And so what's going to happen to your urine that's coming out? Do you think it's going to be high in sodium or low in sodium? Well, it's going to be very low in sodium in a pre-renal situation. And of course, as sodium goes up, guess what else comes with it? Water. And so are you going to have a lot of water in the filtrate, in the urine that's coming out? The answer is no. So you're going to be very low in sodium and very low in water. So that leaves a high concentration or a high osmolarity to the urine that's coming out. Okay, let's look at the flip side of that. Again, here's our glomerulus. Glomerulus, proximal convoluted tubule, loop of Henle, and collecting tubule going out to the toilet down below. Okay, so in this situation, we've got a renal problem. The renal problem is that these cells are not reabsorbing. In fact, none of them are reabsorbing. There's a problem all over. And so what's the situation here? Here we've got plenty of fluid coming to the kidneys, but because these cells are not working, all of that sodium and water is just going right through and out. So we would expect to see a high sodium concentration, a high water concentration, and therefore a low osmolarity to the fluid. And that's in renal, when there's a problem with renal. Okay, so let's summarize once again. Make sure everyone's on the same page here. So we've got the BUN. Okay, what are some of the points that we learned about the BUN? It's synthesized in the liver. Okay, it's filtered and absorbed. Okay, what are things that can increase it that have nothing to do with the kidney? We've talked about that. We've talked about fever. We've talked about GI bleeding. Okay, there's antibiotics like tetracycline. There is catabolic effects, steroids, all that. What are some things that can decrease it? Well, liver failure. Okay, and then what about proximal convoluted tubule? We see there. We see that it parallels the reabsorption of sodium and water. And so we know that it's reabsorbed. Okay, and so because of that, in a low flow state, it's going to be really absorbed. So it's going to go up. Okay. Now, what about creatinine? All right, we know that it's the end product of muscle and that it is filtered and secreted. Okay, so what are some things that can increase it that have nothing to do with the kidney function? We know that it can be increased by drugs that prevent its secretion in the kidney, and that would be cimetidine and trimethoprim. What are some things that can decrease it? Muscle wasting. Okay, and we know that it goes up in renal failure. Okay, well, let's talk about the BUN to creatinine ratio. We know that because the BUN goes up even higher in a low flow state, that it's usually 20-to-1 ratio if it's pre-renal. Pre-renal, again, is any reason that causes a decrease in blood flow to the kidneys, and that it's 15 to 1 in renal. Okay, and in renal, remember, is where there's a problem with the kidney itself, and pre-renal is where there's a problem with the amount of blood flow that's going to the kidney. Okay, now, join me for part 3 for the final wrap-up of acute renal failure. Thanks for joining me.
Pros. Polymer-coated interventional devices are used frequently, and the diagnosis of polymer emboli is unlikely, since emboli usually lodged in the arteriosclerosis of downstream organs.
Hi guys, welcome back to Empower In. My name is Caroline Porter Thomas. Thank you so much for watching my YouTube channel, Empower In. So in this video, we're going to go over a disease process that is known as acute renal failure. Notice that I've already done a video on chronic renal failure, so this is just to go over the acute side of renal failure. Also, another change in this video is I'm not going to do NCLEX style questions at the end. I feel like I'm rushing too much, and the pathophysiology in and of itself is a lot to cover in one video. What we're going to do instead is we're going to have full videos going over one question at a time, which sounds like it wouldn't be enough information, but believe me, with NCLEX style questions, when you're answering one question, you're essentially answering many different questions within that one question. So you'll thank me for it later, I promise you, when you see the videos. So please make sure you subscribe to the channel so that you get immediate updates, and also if you want really fast updates, you can join my email list, which I will put the link below, and I send out an email every time I have a new video. So without any further ado, let's get started and let's go over acute renal failure. Acute renal failure. Humans have 2 kidneys, one on each side of the spine, in the area below the rib cage. They are bean-shaped, each of them measuring approximately the size of a fist. Kidneys are organisms responsible for the filtration of blood and the removal of extra water and waste from the bloodstream through urine. They filter about 120 to 150 quarts of blood per day, producing about 1 to 2 quarts of urine every day. Kidneys play an important role in the normal functioning of the body by maintaining the consistency and composition of the blood. The main functions of the kidneys include reabsorption of essential substances, removing extra fluids and waste from the blood and body as urine via the bladder. They also maintain the concentration of electrolytes such as potassium, sodium, and phosphate. The kidneys also produce hormones that strengthen the bones, maintain blood pressure, and make red blood cells. Acute renal failure, which you will see abbreviated as ARF, and is also known as acute kidney failure and acute kidney injury, is a condition in which the kidney stops functioning all of a sudden. It can take a few hours or a few days to develop. In acute renal failure, the kidney fails to filter out the blood and remove the daily load of toxins out of the bloodstream through the urine. This leads to the accumulation of waste inside the body and disturbs the balance and concentration of chemical substance in the body, which is very damaging. Acute renal failure patients are categorized into 2 different groups, depending on the amount of urine produced over a 24-hour period. Patients can be either oliguric or non-oliguric. Oliguric means that they produce less than 500 milliliters of urine per day, while non-oliguric means that they produce more than 500 milliliters of urine per day. Although non-oliguric patients produce a large amount of urine, but it contains very little waste products, as the kidney hasn't filtered out the blood properly. Risk factors. Risk factors for developing acute renal failure include the presence of a chronic disease like kidney disease, diabetes, heart disease, high blood pressure, or liver disease, blockage of the vessels in the legs or arms, and or peripheral artery disease. Other causes can include bleeding, dehydration, increase in age, usually ages 65 and above, the usage of ACE inhibitors, overuse of certain over-the-counter painkillers such as NSAIDs like Advil and ibuprofen, and naproxen. Causes. There are 3 sites in the renal system that can get affected, causing abrupt renal failure. They are pre-renal, intrinsic, and post-renal. Pre-renal means before the blood enters the kidney. Intrinsic means within the kidney, and post-renal sites are where the urine leaves the kidney and enters the ureters. Pre-renal. If this part is affected, the kidneys do not receive enough blood to filter. The reasons can be dehydration due to diarrhea, vomiting, loss of blood or water pills, disruption of the blood flow to the kidneys due to various other reasons such as narrowing or blockaging of the blood vessel carrying the blood to the kidneys, serious injuries or burns, severe decreases in blood pressure after surgery involving blood loss, or bloodstream infections, especially sepsis, which can cause abnormal relaxation of the blood vessels, and thus not enough pressure to bring blood to the kidneys. Also, liver failure, which can bring about hormonal changes that affect the pressure and flow of blood to the kidneys, heart failure or heart attacks causing low blood flow. In pre-renal failure, the problem does not lie in the kidneys and they remain unaffected in the early stages. However, if the condition persists, they can damage the kidney tissue permanently due to low blood flow in the kidneys. Intrinsic. In intrinsic kidney failure, the problem lies in the kidney itself, due to which the process of filtration becomes faulty or ineffective. It can be a problem in the renal tissues handling salt and water processing, or it can be an issue in the supply of blood within the kidneys. These problems can arise due to glomerulonephritis, which is an inflammation of the initial filtration system in the kidney, the glomeruli. Acute tubular necrosis, in which the tubule cells stop functioning and eventually die. Most of the filtration process occurs in these tubules inside the kidneys. Acute interstitial nephritis is another cause. This means inflammation of the interstitial renal tissue, which is responsible for salt and water processing mainly. Injuries to renal tissue and cells can also be a cause. Also, blood clots within the blood vessel within the kidney can obstruct blood flow, and chronic changes can also be caused by blood vessel disease. And finally, polycystic kidney disease. It is a genetic disorder in which numerous cysts grow in the kidneys. Post-renal. Post-renal failure includes the issues with movement of the urine from the kidneys to the ureters. The problem can be caused by blockage in the way of the urine being excreted by the kidneys. Thus, it is also known as obstructive renal failure. Obstruction in the ureters can be caused by a kidney stone, cancer or tumor in the kidney or in the urinary tract organs, or structures near the urinary tract that may block the discharge of urine, and also some medications. Obstruction in the bladder can be caused by bladder stone, bladder cancer, enlarged prostate, blood clot, and finally a neurologic disorder of the bladder, which leaves it unable to contract. With appropriate treatment, the condition can be reversed. However, if the blockage persists for too long, it can damage the renal tissues and cells. Signs and symptoms. Signs and symptoms of acute renal failure may vary depending on the type and the site of the dysfunction. In most patients, there are no prominent symptoms, but generally the signs and symptoms of the condition can include changes in urination, such as little or no urine at all, or excessive urination at night, vomiting or nausea that can last for days, fatigue, a slow, sluggish movement, hand tremors, prolonged bleeding, bloody stools, nosebleeds, high blood pressure, shortness of breath odor and a metallic taste in the mouth, reduced appetite, non-stop hiccups, flank pain between the hips and the ribs, and swelling caused by the accumulation of water in the body. Also bruising easily, and seizures can occur. Diagnostic test. In case of medical manifestations of acute renal failure, the patient is suspected to have the condition may have to go through certain diagnostic tests and procedures to verify the presence of acute renal failure. These diagnostic tests can include a urine test, which is also known as a urinalysis. It is used to detect abnormalities that can indicate renal failure. Urine output may also be measured. It helps find out the cause of the renal failure because of the amount of urine that's produced over a 24-hour period. Blood tests are also used. It can be used to detect the increasing levels of creatinine and BUN. The concentration of these substances can be used to analyze renal activity. For example, Normal BUN and creatinine levels range from a normal BUN level from 6 to 20 depending on gender, and a normal creatinine of 6 to 1.2 depending on gender. An easy way to track this is to use the symbol key, which you can see a video right here, and also below in the description section. In some cases, a kidney biopsy may be necessary. This is when an extraction of renal tissue is taken, which is done by insertion of a needle in the kidney through the skin. This will be analyzed by a specialist. Imaging tests can also be used, which are used to see the kidneys and include an ultrasound, CT scan, and MRIs. Management. As of now, there are no particular medications to cure acute renal failure, so mainly the treatment is supportive, in which the objective goal is to regain normal renal function. The management of the patient varies depending on the type and site of dysfunction. Normally, the treatment aims to eliminate factors causing the dysfunction, while carefully monitoring the electrolyte and fluid balance and correcting hemodynamic status with the right fluid therapy. Treatments suggested to avoid complications include dialysis. Dialysis is the process that removes toxins from the blood while allowing the kidneys to heal, for the removal of excess water and accumulated toxins from the bloodstream. Temporary hemodialysis may be necessary. It is also used to remove excess potassium. Dialysis is done by pumping blood out of the body with help of the machine, which is then pumped through a dialyzer that works as an artificial kidney. The dialyzer filters the blood and removes waste, after which the blood is returned to the body. Diet modifications. In order to control the accumulation of toxins that are normally filtered out by the kidney, the doctor may limit the amount of certain foods and liquids. Your patient therefore may be placed on a high carbohydrate and low protein, low salt, and low potassium diet. Other treatments can include medications to restore the level of calcium in the blood in case of a drastic drop in blood calcium level. In case of a drastic drop in blood calcium level, the patient may have an infusion of calcium ordered. Medications to maintain the level of potassium in the blood. When the kidneys fail to remove potassium from the blood, a doctor may order substances such as glucose, calcium, or another medication called K-exolate in order to remove the excessive buildup of potassium in the bloodstream. Excess of potassium can result in weakening of the muscles and irregular heartbeats or arrhythmias, which can be dangerous. A trick to remember this medication is by saying the name of the medication out loud, which sounds to me like K-exit or K-exolate, which means potassium is exiting. And finally, treatments to regulate the amounts of fluid in the blood. In cases of hypovolemia, which means low blood volume, there is found to be inadequate fluids. These fluids can be administered intravenously. Sometimes acute renal failure can also lead to excess fluids, resulting in swollen hands and feet. In this case, your doctor may order a diuretic that causes the body to expel the excess fluid. Prognosis. Reversal of kidney failure depends on the cause of the disease. Full recovery is possible in the case where the disease does not originate from the kidneys and renal tissues are unaffected. If the dysfunction is not correlated completely, the patient may recover only partially. Generally, the after effects depends on how sick the patient was in the beginning of the disease. In severe cases, acute renal failure can cause death. Alright guys, thank you so much for watching. We really hope that you enjoyed this video and learned a lot about acute renal failure and the pathophysiology. Like I mentioned before, make sure you subscribe to the channel and also sign up for email updates, because as we finish editing the questions, we're going to start posting the video questions with the rationale. If, however, you do have an exam coming up, make sure you go ahead and go to my website, because we have the questions already typed and available there. So anyways, we can't wait to see you again soon. Love you. Bye.
Cons. The associated events range from unoctave events to myocardial infarctions, stroke, and death within days to months. Computed tomographic angiography revealed the stenosis of the common iliac artery.
Hello, this is Andrew Wolf. In this video I'm going to talk about acute renal failure. Now, I want to make a point that acute renal failure and acute kidney injury are often used sort of synonymously in clinical practice, but they are not synonyms, and I wanted to talk about how they are similar and how they are different. Now, acute renal failure can cause acute kidney injury, particularly there are various mechanisms to cause injury to the nephron, and also acute kidney injury can lead to acute renal failure, but they are not synonymous. Acute kidney injury it refers to injury to the cells inside the nephron, and acute renal failure refers to the failure for the kidney to perform its normal functions. For example, the kidney loses its ability to excrete wastes, and in the labs we see a increase in BUN and creatinine. Also, with acute renal failure, the kidney is no longer able to maintain a balance of electrolytes, and we see a increase in plasma potassium, which can be quite dangerous, and we can also see other derangements of electrolytes with decreases in plasma sodium concentration, and also we can see imbalances in pH as well. Now, I want to talk about three different causes for acute renal failure. The first is pre-renal, and this really refers to the kidneys failing because there is a problem with blood flow to the nephron. Now, the second cause is the opposite of that. It's renal failure that's caused by obstruction beyond the nephron. So this is called post-renal failure, and we end up with an obstruction in the ureters or the bladder, and this causes a disruption of the ability of the kidneys to perform its function acutely. Now, the third type is renal failure that is caused by damage to the nephron itself. Now, this could be caused by damage to the glomerulus in glomerulonephritis, or it could be caused by damage to the tubular epithelial cells. Okay, so I wanted to start by talking about pre-renal failure first. Now, pre-renal failure really refers to renal failure that is due to disruptions in flow to the glomerulus. So if we have decreased flow to the glomerulus, then this can interfere with the nephron's ability to perform its functions. So this really refers to decreased flow through the afferent arterioles. Now, several things can cause this. Chief among them is decreased cardiac output. Now, we could have decreased cardiac output because we have a person that has just a hypotension, or we could have decreased cardiac output because we have a patient that has congestive heart failure. So, if we have a patient that has a ejection fraction that decreases from a normal of 55% to a very low level of 20% because they've just had an acute MI and lost the function of much of their left ventricle, then this will cause acute renal failure due to acute congestive heart failure. Now, sort of related to blood pressure, the most common cause of hypotension is often volume. So these are sort of related. Blood pressure could also drop because of massive vasoconstriction, or it may drop because of decreased volume. Now, I made the point here that with decreased volume, you're going to see decreased jugular venous distension, and with CHF you're actually going to see increased jugular venous distension. So if you have a patient that's going into renal failure, it's a good thing to sort of keep those things in mind. Now, the next part of acute renal failure, pre-renal acute renal failure, I want to talk about is renal failure that's caused by vasoconstriction. Now, vasoconstriction in this day and age is most commonly caused by derangements in prostaglandin. Prostaglandins in the kidneys cause vasodilation of the afferent arteriole. However, there is a class of medications that most of you are familiar with, of course, known as NSAIDs, or non-steroidal anti-inflammatory medications, and these interfere with prostaglandins. Now, this is obviously beneficial when we are trying to block prostaglandins in the periphery of the body, where the prostaglandins are causing inflammation and pain. However, the NSAIDs are blocking prostaglandins throughout the body, and so it interferes with the prostaglandins' effect on causing vasodilation or maintaining a proper vasodilation in the afferent arterioles. And this can cause vasoconstriction, and it can cause pre-renal acute renal failure in patients that are susceptible, particularly patients that have decreased volume status. Now, the third cause of pre-renal acute renal failure is vaso-occlusion. Now, this is most frequently caused by emboli or arteriosclerosis of the arteries that are feeding the kidney. Now, if you have emboli or microemboli that are disrupting the flow to many nephrons, you are going to have pre-renal failure that is causing intrarenal failure, because you'll have ischemia and necrosis. Now, decreased cardiac output and vasoconstriction, if it is severe enough, can do the same thing. If you decrease blood flow through the afferent arterioles to such an extent that it not only interferes with the function of the nephron, but actually causes damage to the nephron itself, to the cells within the nephron due to ischemia and necrosis, then this will lead to intrarenal failure. Now, intrarenal failure really is caused by damage to the nephron, and the damage to the nephron may be transient, in that cells are injured to the point where the nephron is injured to the point where it cannot function, or it could be permanent, where the damage to the nephron is so severe that the nephron becomes scarred and completely dysfunctional. Now, in most times in clinical practice, when we have acute renal failure, it is transient, even if it is intrarenal. So there is injury to the cells, there is injury to the nephron, but the nephron is able to repair itself and recover once blood flow is brought back to normal through the glomerulus. Now, in the nephron, there are two general parts that could be damaged. The glomerulus could be damaged, or the tubular epithelium could be damaged. And this sort of helps guide us to two possible sort of general causes of intrarenal failure. So if you have damage to the glomerulus, you have intrarenal failure that is caused by glomerulonephritis. If you have damage to the tubular epithelium, then you end up with acute renal failure from intrarenal causes. That is due to damage to the tubular epithelium, which is known as acute tubular necrosis. So these are both intrarenal causes of acute renal failure. Now, glomerulonephritis may be caused by infection, and infectious causes. What happens with when you have an infection is that you actually have bacteria, most commonly strep, that is bound appropriately to immunoglobulin A. Now, what happens is we end up with a bunch of bacteria, or actually you end up with little parts of bacteria, the protein and such, that bind to the immunoglobulin A, and then you end up with these big sort of conglomerates of the immunoglobulin with the proteins. And when these sort of float through the bloodstream, and you end up in the glomerulus, and you can see here these are the endothelial cells with the fenestra, and then behind them we have the podocytes with their little slit pores, and these tiny little fenestrations and slit pores get clogged up by these big conglomerates of immunoglobulin and proteins. And once they get clogged in there, they end up causing inflammation of the glomerulus, hence glomerulonephritis. So we end up with severe inflammation in this area, and it also disrupts the filtration through the glomerulus, and hence it causes acute renal failure. Now, the next cause of glomerulonephritis is actually an autoimmune reaction, and this is actually very similar to the infectious reaction, except the immunoglobulins are not binding with bacteria, the proteins from bacteria. They're actually binding with self-proteins. An example of this is a type of glomerulonephritis called rapid progressive glomerulonephritis that is also called pouchy immune glomerulonephritis. And this is caused by anti-neutrophil antibodies that bind with proteins on neutrophils and cause the exact same reaction. You end up clogging up the fenestrations of the epithelial cells inside the glomerulus and clogging up the slit pores and causing inflammation. So again, these are anti-neutrophil proteins, and it causes the exact same reaction. And the inflammation makes the process worse. The glomerulus is not able to function because it's not able to filter, and we end up with acute renal failure. Now, the next type of intrarenal acute renal failure is due to acute tubular necrosis. If you remember, the tubules in the kidneys, the epithelial cells, are very dependent on a constant supply of oxygen and energy. They're hypermetabolic, and they do not deal well with ischemia. They are injured very, very easily. Now, if you remember, these cells are very hypermetabolic. In fact, behind the central nervous system, the epithelial cells in the kidney are the most hypermetabolic cells inside the body itself. You can see here inside the cell I drew a bunch of little purple mitochondria cells. Remember, these cells are packed with mitochondria. They are constantly making a lot of ATP to run the sodium-potassium pumps and other ion pumps within the cells. So they're very, very hypermetabolic. Now, if you look inside one of these tubules and you look at the epithelial cells, when they get injured, they actually start to slough off. So when we have ischemia and necrosis, we end up having the cells slough off, and they actually can clog the tubules. And when you clog the tubules, then you don't get adequate flow of filtrate through the tubules, and this obviously is going to interfere with the function of the kidney, and it's actually going to cause a type of post-renal failure. Now, before I get into talking about post-renal failure, I want to talk a little bit about other causes of acute tubular necrosis. So, ischemia is one of the causes. Another major class of causes are drugs and toxins. Again, the epithelial cells of the tubules are, again, very sensitive to loss of oxygen, but they also can be very sensitive to drugs and toxins. And obviously, if you have injury, direct injury to the epithelial cells can be destroyed, and they cause the same problems that I mentioned when we talked about ischemia. Now, a third type of acute tubular necrosis is due to hemolysis. Now, hemolysis can cause direct injury to the epithelial cells, just like drugs and toxins, because hemoglobin, obviously the breakdown product, particularly the heme in hemoglobin, can be directly toxic to the epithelial cells in the tubules. Also, hemolysis can also cause a glomerulonephritis because the breakdown products of red blood cells and the coagulation that can be stimulated by the rupturing of red blood cells can cause a microangiopathy and damage the glomerulus itself, sort of clog up and damage the glomerulus. So hemolysis can cause a intrarenal failure and damage to the nephron in both the glomerulus and the tubules. Lastly, I want to talk about post-renal failure. Now, with post-renal failure, you need to think about urine that has flowing freely from the nephron and into the renal pelvis and down the ureters to the bladder, and then from the bladder out the urethra. So post-renal failure is caused by something that disrupts this flow. Most commonly, it is caused by renal calculi, or kidney stones, that can clog up the ureters or the urethra itself and cause a backflow of urine into the nephron. It also can be caused by masses, like from bladder cancer, or it can be caused by masses in or around the urethra, compressing on the urethra, like severe benign prostatic hypertrophy or prostate cancer. Now, anything that disrupts the flow of urine from the renal pelvis will cause a backflow or back pressure in the nephron. And if you have significant back pressure in the nephron, if you trace it all the way back up to Bowman's capsule, and you increase the pressure enough in Bowman's capsule, then you no longer have a net filtration pressure, where you have a much greater pressure, hydrostatic pressure, coming from the glomerulus and pushing fluid across the membrane into the Bowman's capsule. Remember, because filtration pressure is caused by a difference between the high pressure in the glomerulus and the low pressure in Bowman's capsule. But if you increase the pressure in Bowman's capsule, then you're no longer going to have flow of plasma across the glomerulus, or flow of filtrate across the glomerulus, and this will again interfere with the kidney's ability to function, and you'll end up with post-renal failure. Okay, before I wrap up, I want to talk about sort of the major causes of acute renal failure, at least in my own clinical practice. Volume is probably number one, decreased volume status. Number two is the use of nonsteroidal anti-inflammatory medications. And number three is acute tubular necrosis that is due to ischemia. And then number four would be drugs and toxins. So these are going to be the four things that I would consider most prominently if I have a patient with acute renal failure. So again, pre-renal failure, the most common cause is going to be decreased cardiac output due to diminished volume status, or NSAIDs. And then intrarenal, the main cause would be injury to the epithelial cells of the tubules due to ischemia, or due to drugs and toxins. So this sort of scheme of looking at renal failure is very, very useful, because number one, your first step in trying to diagnose a patient that has acute renal failure is to consider, is it pre-renal, intrarenal, and post-renal. Now, post-renal is the most rare, but it's always important to rule it out because it is usually easily reversible. If you do an ultrasound and you find someone with a big kidney stone that's blocking the ureters, then you can quickly intervene and take care of the problem, and you're done. So always consider it, even though it's probably the least common that cause of acute renal failure. Then you and I'm not going to get into the details here, but there are ways to differentiate between whether it's pre-renal or intrarenal. If it's pre-renal, you're going to consider, is the patient on NSAIDs, or do they have decreased volume, or both? If it is intrarenal, then you are going to decide, okay, does this patient have ischemia, or are there drugs or toxins that are potentially causing injury to the epithelial cells of the tubules? Okay, so this concludes my video on acute renal failure. I hope this was helpful to you, and as always, you are welcome to ask questions in the comments below, and I'm going to put up a couple of links so you can have quick and easy access to my other physiology videos, including the quick and easy access to the physiology of the renal system. Thank you very much.
Issue applied in Ecuador. This renal lesion may be induced by hydrophilic-polymer emboli. We speculate that the stent in the iliac artery was the most likely source of the emboli in light of the anatomical proximity to the anastomosis. Conclusion. In conclusion, the current case highlights what they consider to be a under-recognized iatrogenic complication. Embolic foreign material may be present in patients who have undergone recent implantation of an intravascular device with a hydrophilic coating.